right, so I know everybody's been sitting for a little while. I'm tasked with going through lower extremity pediatric fractures, which is a very broad topic. So rather than try to highlight, each in as little depth as possible, I'm going to really focus in on femur fractures. Because I think there's a lot of stuff that we can learn from a pediatric femur fracture, and there's so much variability within our age range. So we're going to go through that, and then I'm going to just do a quick rapid fly through the others just to kind of give some brief overviews. Interrupt me if you have questions. For those that don't know me, I'm pretty easygoing. For those that do know me, you know that you can ask me questions, and I'll try to give you the real approach rather than just the textbook approach. And I will get started here. My email address, I usually have it on the last slide. So that's available, and then typically one of the chiefs or somebody can, or Delalo, since he's on service right now, can get this presentation from me if anybody wants it in detail. I know we're also being recorded though, so you should be able to have multiple ways to review all of this great stuff I'm going to try to go through for you here today. All right, so basic pediatric fracture workup. I always want to just kind of take a step back, and we're doctors. We still have to approach things systematically. Think about time of injury, the mechanism of injury. I put occupation in quotes here because kids, even though they don't have a true job, they have things that they do. So thinking about sports, dancers and so forth. Their goals of recovery is going to be based off of what their occupation is. Other basic history, their NPO status is obviously very important for anything more urgent. The physical exam, sorry, I'm using presenter mode. I was looking at my next slide, hence the troubles of Zoom presentations. So fracture workup. We usually already know when you get the consult that there's a fracture. Typically you're getting called with that. Present to the situation though as if you do not know that there's a broken bone, and work it up appropriately. In the trauma setting, it's a little different than the ER bay versus an office setting. So kind of think about what you're doing, how you're approaching it. This is the slide I was starting to talk about. We're doctors, we have to approach things appropriately. So, the history is very important. Like I said, sort of the occupation is a little bit different for kids, but I think it's still very important to know kind of what our goals are for recovery, and also setting the expectations from the beginning, what to expect. Physical exam, the basic tenets, inspect, palpate, get a good neurovascular exam. For those that haven't done peds before, that neurovascular exam is a little bit difficult. You don't always get that clear, move your big toe, flex your ankle up and down. You have to sort of take what you get, and sometimes trick people into doing stuff. So tickling of toes, you can check to see if they're able to sense and if they're able to move. So you sort of use your full gamut of physical exam skills, and observation really is something I think is very important that you may not think about with a pediatric physical exam, is just watching what they do when they don't know they're being watched. Very rarely we'll also get some special tests with a physical exam. Things like ankle brachial index you'll get in the adult world sometimes is important, and there's a couple that I'll highlight in specific cases for the peds world. Stability is also another thing. It's difficult to assess stability of a knee if there's a fracture above it, but we do need to account for that just like you would in the adult world. Trauma patient is, just like in the adult world, a very kind of unique population where, we participate directly with the other services. We don't fall in the immediate ABC range, but you need to be aware that our injuries are rarely trumping anything that is involved with an A, B, or C. So always take our sort of second fiddle until we're ready to chime in. But our presence in the trauma bay is very important, no different in the pediatric world. For lower extremity traumas, you're looking for deformities. abrasions, lacerations, or especially slow oozing bleeding can direct us to either open fractures, or at the very least, you know, you get a bruise over an area that could be a site of another fracture. So getting x-rays of those appropriately. Palpating extremities for crepitus and fractures, as well as compartment syndrome, is a very important thing. Less common in the pediatric world, but at the same time, very important to utilize your skills to identify. Move your joints to see if there's any blocks to motion, swelling, etc. Those joints, spine exam, and then the other injuries is sort of the thing to be aware of with the pediatric population. Not always will they break bones, but they may have some solid organ injury that may affect our getting to treatment of those injuries. Pictures of x-rays, you know, basic tenets, x-ray of the injury itself, but then also make sure that we're seeing the joint above and the joint below. Kids have physes, so the physeal injuries right above or below need to be evaluated as well. So you need to see that joint. Always need to see two views. One view is no view, as I was taught in residency. And then there are some special views that you'll need to get, potentially, you know, traction view for a femur film or otherwise. So check in if there's anything unique to specific injuries. But for the most part, pediatric trauma is the same as an adult trauma and working it up. We just need to be aware of the growth plates as the injury, which is where, you know, I think no fracture talk is complete in pediatric world without at least showing and highlighting the Salter-Harris injury classifications. So the basics of the Salter-Harris injury, again, type 1 is a injury through the growth plate, where there isn't involvement of either the metaphysis or the epiphysis, so it's truly just through the growth plate. Type 1s are distracted. Sorry, for whatever reason, they're labeled ABC, but we know it's 1. Type 2 is through the metaphysis. Type 3 through the epiphysis into the intra-articular space. Type 4, crossing the physis, that includes both a metaphyseal and an epiphyseal fracture fragment. And these have a high rate of growth disturbance. So be very mindful if you see these to start talking about the potential for growth arrest. Type 5, probably the hardest one to identify because of the fact that you do not see a fracture line. It's the compression of a physis. This is where contralateral films can be very important to see a type 5. Finally, this sort of like a type 6 or an other is an injury to the perichondral ring of LaCroix. That's an injury that can also lead to pretty high rates of growth disturbance and specifically angular deformities. So now that we've kind of talked a little bit about the radiographic pediatric classifications, the other thing is mechanism of injury. And there's a little bit of a morbid picture, but at the same time, it really highlights the difference of what you're going to see in a pedestrian versus an auto. You know, the general, you're going to see, you know, tibial plateau injuries, you know, distal femoral fractures from a pedestrian versus auto. But you can see the spectrum of a child, like a toddler. You know, they may be getting run over. You may think about pelvic injuries or head injuries, spine injuries. A child is going to get more of a proximal femur, kind of trochanteric or subtrochanteric femur fracture. And adolescent or sort of a preteen may get more of a midshaft femur fracture. So you can see how, you know, the pediatric size and shape may lead to a slightly different fracture pattern based on the mechanism of injury. Additionally, I don't have the slide here, but I think it's important to think about in a motor vehicle accident or pedestrian versus a vehicle. When kids get injured, they may have their limb injured, but then if they get hit, they'll frequently also bounce onto the top of the car and get either a rib or a head injury. And those are actually the bigger determinants as to long-term survival and function. So from the standpoint of, we get a pedestrian vehicle accident, if you get the midshaft femur fracture, really think about and ask the trauma service about head injury and, you know, kind of rib injuries as well as to whether or not those are involved. So, like I said, I really wanted to highlight sort of one major fracture pattern and then move on. So, pediatric femoral shaft fractures, one of the most common pediatric lower extremity fractures that require surgery. And it is the most common pediatric fracture that requires hospitalization. So it is definitely something that we see, take care of. I did one over the weekend in the OR, and I took care of one in the ER. And this is a very busy kind of graph, but I'm going to kind of break this down, and we're going to really focus in on this. This is from the JAOS Flynn article back in, I want to say 2005. So it's a while ago, but it's really the same basic concept. And for those that have taken care of peds, there are some basic breakdowns of how we take care of things in a pediatric population. So, Charlie, I see you on video, and I know you've recently been to CHO. Tell me about kind of the basic breakdown, and you've got these 4 categories here. What is the basic treatment for those injuries, like a femur fracture in a 0 to 6 month old?
Yeah, so not a one size fits all because of different ages and different ability to tolerate various treatments. Also variety in size of implants, rate of patient growth, all things that sort of complicate what you can do. So generally speaking, like a 0 to 6 month old, usually you can actually treat those patients in like a Pavlik harness, which is pretty unique. We don't really think of that as being a treatment option in the adult world. And they'll generally do pretty well. 6 months to 5 years old, your options begin to increase, and people will debate, how late, is 5 years. Basically, treatment option is a spica casting, and people will debate sort of how long patients can tolerate that, right, until when. And then 5 to 11, you kind of get out of the spica casting age group because kids definitely can't tolerate being that constrained for so long. What's that?
Kids and parents, I would say.
And parents, yeah. And then once you get to 5 to 11, then you have other options in terms of actual surgical treatment and, flexible nails. We could probably talk in greater depth about appropriate criteria, but there are weight limitations to flexible versus rigid nailing. And then generally speaking, you can start to think more traditional adult treatment options once kids are, greater than 100 pounds, which tends to be over 11. Oh, that's my dog.
Dog is right down there, so I agree. All right, yeah, absolutely. I think that's a pretty good basic overview. For those that have never, taken care of kids, or you've never seen a Pavlik harness, it is crazy to just think that we've got in a 12-year span, we've got 5 sort of major modalities of care that are broad spectrum. And that's, I think, why I really wanted to focus in on this setup of fracture care for kids. So with the standpoint of this graph, I've gone and I've highlighted the areas to kind of give a little bit more of a, what do we do when? And, break it down into this graph to kind of highlight what exactly is happening here. So in the y-axis here, the energy of injury and sort of the pattern of the fracture is borne out here. So essentially low energy is on the bottom, high energy is on the top, and the higher energy injury, we were thinking also more comminution, more length unstable type patterns. And so the ages down on the bottom, you can see, are broken down into, sort of this little segment here. The Pavlik harness is usually thought of as a management of DDH, a hip dysplasia. You're using the harness to kind of put the femoral head deep into the socket. Well, in fracture management, you're kind of just utilizing this as a temporary splint. It's a relative stability, very relative, I would say, stability that essentially just puts the kid into a position and holds them there for a little while. Jen, I don't know you. O'Donnell, I don't know you, and I don't know your year. Are you
I'm a
first or
second
second year at
year.
least?
Second year.
Second year. Um, what kind of a timeline do you think you need for fracture healing to become, relatively stable with the a fracture before it's, uh, moving around too much that they're having pain? Like, how much time do you think you need a fracture to heal in a 0 to 6 month old? Like a couple of days, few weeks, months? What
Yeah, I
timeline?
think especially because they're not weight bearing on the leg, like older children, you could do probably like 3 to 4 weeks.
Hmm. Yeah, it is probably even less than that before they're starting to, provide some like callus. So usually in the first like 2 weeks, they're having some discomfort. And then usually by like week two, they're perfectly fine. And you get an x-ray around week two and you just see this massive ball of callus around. So kids in that 0 to 6 month age, they heal like gangbusters. And essentially, their bone is already pretty stable after a couple of weeks, which is why you can get by with having such a minimal use, or a minimal stability construct of a Pavlik harness. Spica casting then is sort of the next big bulk. That's this, blue region here. That is really a broad category, but you start to see some overlaps as you get into sort of the 3, 4-year-old category where you can start to treat other things. But immediate spica casting is, the next, within 24 hours, putting a cast onto that child. That is sort of the mainstay of treatment for femur fractures in young kids. Ultimately, though, you need a child big enough. So 6 months is sort of where the kid becomes big enough to really easily get a cast on them. And then as you get up into the 4, 5, 6-year-old range, they're really just getting too old to functionally have a child in a cast. So for those that have kids, if you imagine putting a 4 or 5-year-old into a cast that's already up walking, they're peeing and pooping on their own, you're doing all these things, and then you lock them into a cast, that's a life-changing experience for the first few months. So that's usually our mainstay of treatment, but that's something that starts to overlap a little bit as we get farther along. The 5 to 11 years, you start to, like Charlie said, get more surgical options. Even though the spica cast goes on in the operating room, there's no incision, there's no implant. In the high energy injuries and multiply injured patients, external fixation is always going to be a category that you can use. That is something that we have. Definitive treatment with external fixation isn't ideal because of the fact that it's fairly stiff construct, and if you use that for the long term of fracture healing, it can actually reduce the rates or reduce the rates of healing, increase the rates of non-union. So we actually are careful to treat definitively a femur fracture with external fixation alone. When you can convert external fixation to an internal fixation, that's typically an ideal. The bulk of kind of the lower energy injury, and in specific, the stable pattern, so a transverse or a short oblique fracture, using flexible nails is really a good option. And we'll talk more about that because that is a distinctly pediatric fracture management. The rigid intramedullary nailing then, that really becomes, once you have a trochanteric apophysis that's become more skeletally mature, typically, lowest of 10 years old, I would say, but usually in sort of that 11 to 12-year-old and up, we're using a trochanteric entry nail and doing a more classic intramedullary rod. Let's see, Sergio, you are an intern, I believe,
Yes.
Correct? All right. So anatomy question, and we'll highlight it later, but why a trochanteric entry nail for a pediatric femur fracture?
Instead of going like
Piriformis,
retrograde, or
a piriformis entry nail.
why use a piriformis instead of a trochanteric?
So why use a trochanteric, not a piriformis entry nail?
Oh, that I'm not actually sure, but I think, does it have to do with like, I guess the physis would be further towards the femoral head, so you wouldn't have to worry about that. but maybe like blood supply to the
blood supply. That's exactly it. So you're actually less worried about the physis in this because, like you said, the femoral head epiphysis is really far away, but your blood supply, in specific, the medial circumflex artery, is right at the piriformis fossa area, and in a pediatric population, that is critical for blood supply to the epiphysis. So if you lose that, you wind up with a high risk of AVN. So it's always a trochanteric entry nail for our rigid intramedullary nails. All right, so other considerations. This is where this graph, and I have another talk where I kind of expand and contract these sizes of the graphs. You always have to think about considerations. I don't have a clear slide for my social determinants of health slide like Dr. Livingston was talking about, but this is where I think we really do have to think about the socioeconomic considerations of our patients, because not everybody has access to a stay-at-home care provider for a child in a spica cast. So not all 3-year-olds can sit there in a spica cast, which really, sometimes will prevent kids from going to a preschool, prevent kids from going to a school. So we do have to think about and really talk with families about how treatment options are available. And sometimes the short-term risk of doing a flexible nail is better than putting a child into a spica cast, even though the spica cast leaves no hardware, leaves no scars and so forth. So there are some very important things that when we sit there and talk about it, because there's overlap in our treatment, we don't have a one-size-fits-all. And I think this is a nice opportunity to, really kind of think about and approach family and, the dynamic of, the support network, the social structures, mom or dad, the, sole provider, and they are working their job and they can't, have a child not in preschool. So those are things that we have to think about and really consider in the pediatric femoral shaft fractures. I didn't have a great way of putting these onto the slide, but this is the AOS Femur Fracture Guidelines. I definitely would recommend taking a look at it. In general, there's a lot of stuff that's unable to be formally recommended. So there's a lot of guidelines, but there's a lot of unable to determine if weight should base treatment, unable to recommend for non versus non-locked plating, or locked versus non-locked plating, so forth. The bolded ones here are the ones that really need to be kind of held in a higher level of evidence. And this first one is that children less than 3 years of age should be evaluated for child abuse. Anthony, why do you think a child less than 3 with a femur fracture is an important person to question for non-accidental trauma?
Because in a 3-year-old, I imagine it would take a higher energy to cause a femur fracture. So not just a fall or something like that.
Exactly. So the energy to break a femur is fairly high. In a 3-year-old, most of the time shouldn't be able to create that energy, or they may be put into like a neglectful situation where they have unsupervised time on a playground and they were climbing 6-foot ladder and fell type of a thing. So it's like we should think about, why did this happen? And the age 3 is sort of that, toddlers can run and jump and fall. The older you get, they can put themselves into precarious positions. But less than 3, child abuse does substantially increase with a femur fracture. So at the very least, they should be evaluated. And that's what the guidelines are. Not that they have it, but that they should be evaluated for non-accidental trauma. The other level 2 is 6 months to 5 years with less than 2 centimeters of shortening. The treatment is spica cast. Greater than 2 centimeters, it becomes a little bit of a difficult thing to assess. That's where there was some immediate or temporary traction and then spica casting. So there are some approaches to address the greater than 2 centimeters, but we don't have great evidence to say exactly what to do with those. Flexible nails are an option from children 5 to 11 years old. Is the only other level 3 or higher evidence from those guidelines. So not great level of evidence, but they're just saying it's an option in that age range. So high energy trauma, the motor vehicles and whatnot are where we see most of our femoral shaft fractures. Again, child abuse should be considered if less than 3, but then we do have some unique features of pediatric care that you may see a femur fracture without clear, clear high energy trauma. So osteogenesis imperfecta, neuromuscular, so kids that have spasticity or other gait disturbances, they may not be up and walking, so they may have some baseline osteopenia, including spina bifida, where there can be some neurological components to the bone healing and bone development. Metabolic, so rickets, vitamin D deficiency conditions, we can see that, and then pathologic. So if you ever see a fracture that has a big cyst in the femur or proximal or distal femur, that's the other sort of typical thing that we would see. So spica casting, or excuse me, Pavlik harness right here, again for the 0 to 6 months old, is a great method of treatment. The first couple of days they're having some discomfort, but generally pretty quickly as that callus develops, they wind up not needing anything more. So this, you can see the little buckle right here is the Pavlik harness on, and it just sort of holds the leg out in an abducted, flexed position, which is generally what the femur needs for just gross alignment. The deformity can be fairly substantial, and it doesn't matter for the most part because kids at this age remodel, they address their length so well that we do not have to actually stress about it too much. In a child that has multiple injuries or limb shortening of greater than 2 months or 2 centimeters in this 0 to 2, it's really uncommon, but sometimes what you can do is you can do some skin traction for, you know, about a week, get some soft callus formed, and then transition to a spica cast after a few days. So I've done that a couple of times in practice. It works well, but it sort of addresses that really, you know, short femur that you don't want to just cast alone. 2 centimeters has always been sort of our watershed line, that if you are less than 2 centimeters, typically the injured side will overgrow a little bit, so you can address a little bit of that shortening based off of the fact that we expect there to be some growth. The hip spica is sort of the classic treatment. The cast holds the leg in, again, sort of this general abducted position. You can address the flexion extension to accommodate the alignment of the fracture. And again, you know, we do not care so much about the major deformity like this because you'll get a ton of callus. A little bit of shortening is accepted up to about 2 centimeters. And then we will address, you know, leg lengths over time and watch them heal. Alejandro, what are the deforming forces on a femur fracture that you have to accommodate in a spica cast?
So I think for a femur fracture, you would be worried about like the glutes, pulling it into internal or external rotation, pulling on the trochanter there. And then you also have the quads pulling into flexion. And then I'm sure there's some more too that I'm not thinking of here.
Right. I think that's pretty good. And it's hard. I'm only showing you one view right now, so it's difficult. And this is the casted view to accommodate the deforming forces. So you were right about the troch. Sort of the abductors are going to kick the proximal fragment out into abduction, and then the distal fragment is going to kick into adduction, which is going to give you a varus deformity. So you have to worry about a varus deformity on the AP, and on the lateral that we have here, you actually worry about the hamstrings doing some overpull, because again, the proximal fragment will flex some and the distal fragment will flex some. So you'll get a procurvatum. So the deforming forces that you address, and why I have a spike directed posteriorly here, is that I actually want to make my mold an anterior mold to put it into slight recurvatum, and then on the AP, which I don't have a great X-ray, I thought I did. You want a little bit of valgus on your fracture, because the tendency will be to fall into procurvatum and varus. Spica cast, I have on here real quick, a couple other little studies that are helpful using single leg versus a double leg, and then this sort of walking spica cast. As you get a little older and the leg is long enough that you can get control of the fracture without going to the contralateral limb, using a single leg has been shown to increase patient's mobilization following cast removal. So essentially giving a single leg spike, which I have right here, you can allow for the child to start to walk a little bit as they get up towards the tail end of their time in the cast. That is something that's helpful to get them up and moving, and it can decrease decrease time to mobilization. Again, the external fixation, not ideal, but can be used for definitive treatment if necessary. You just have to be aware of the potential for growth disturbance. As we get into femur fractures in the sort of 6 to 10-year-old range, sort of 6 to 12-year-old, which is the most common situation, then we look at flexible nails. They can be called Nancy nails, tens, Ender's nails, many different ways, but essentially two counter position nails that are intramedullary, that are outside of the physes. So they allow for growth remaining. They provide good internal splinting. Additionally, you still have traction as an option, external fixation, trochanteric nail, and submuscular plating, depending on the age of the child and their skeletal maturity. So the older, the same child here may have some unique features. The more subtrochanteric you get, you may want to do what's like a retrograde and an antegrade nail, to get better control of your proximal fragment. Additionally, doing external fixation or submuscular plating, which essentially acts like an internal external fixator, can be utilized for more of these multiply injured or kind of unique fracture fragments. Flexible nailing, and I'm going to go kind of quick through this because I'm looking at the time, and of course we're running out. The nail size is typically 40% of the canal diameter, which means that you wind up with 80% fill. So if you think about 80% of your canal should be the intramedullary nails. When you look at it in cross section, you take the canal diameter at the isthmus, and you get about 40% of that. That's the size of your nail. The other thing that's important is you have to use the same size nails. So it's not like you use a 3.5 on the medial side and then a 4.0 on the lateral side. They need to be the same size, because what you're doing is you're actually using the elastic properties of the nail to push against the bone. And if you have one that's stronger, it's going to kick it into deformity on the side of the stronger nail, because these rods want to be straight. We're putting them in bent, and they are deforming, trying to become straight. So they're essentially lengthening slightly, and they are providing that sort of outward pressure to splint this splint this fracture while it heals. You can use the flexible nails as a reduction aid. So for those that have used the ugly finger or the traction or the internal device on the guide wire for your femur fracture, you can use that to help guide your guide wire past. You can also do that just with your flexible nails here. So it's a nice little trick when you're doing the case. And it's about 2.5 centimeters proximal to the physis. Complications, the heavier you are, there is a slightly higher risk of a loss of reduction. So using 50 kilograms is sort of our cutoff. 100-pound, 50 kilograms roughly, is where we say that we would bump to a higher strength construct. Additionally, length unstable fracture patterns, so long spiral fractures or comminuted fractures, flex nails do not work. They're non-weight bearing until their callus shows. And then implant removal is one of the things that, whether it's a complication or not, we don't necessarily always remove hardware, but it's quite often that we do. I think we're hitting the 11 o'clock. So let me get to the last couple of slides here. femur fractures in greater than 11, you wind up really not doing early spica because it's just not feasible to put a child in a spica cast if they're greater than 10 years old. So then we look at, the flexible intramedullary nails are possible for smaller kids, but again, they're usually hitting that 50 kilogram, 100-pound, and we can't use a flexible nail as the option. So then you get to the intramedullary nail like you would expect in your adult life. The main difference is that these are all going to be the lateral trochanteric entry nail to avoid the piriformis fossa and the blood supply. With these kids, they sometimes also come with much higher energy injuries. So this was an open distal femur fracture, used Xfix temporarily, and then put in this submuscular plate, using it as an internal external fixator construct, where it slipped underneath of the vastus lateralis laterally. Finally, the medial femoral circumflex to make sure that, I think Sergio this, the location of our medial femoral circumflex artery is right at around the piriformis fossa. In a child, that goes up to and provides blood supply for the growing femoral head. If those are disrupted, it winds up causing high rates of AVN, and so we do not do a piriformis fossa. We do a lateral trochanteric entry site to be down on the lateral aspect of the trochanter to avoid any risk of an opening reamer or blind placement of guide wires to damage that medial femoral circumflex. Submuscular plating technique that I think you get some in the adult world, but we'll utilize occasionally from a pediatric standpoint in length unstable. So if you get a big butterfly fragment that doesn't allow for good flexible nail, using a submuscular plate is pretty convenient. Using lots of small little incisions just makes for hardware removal a little more difficult. So not something that we go to on a regular basis. So removal of hardware in the pediatric world, we do sometimes do it. In fact, my day today was 2 hardware removals. So I think, it's something that we quite often do, but that is one of the discussion points that we have with kids when we do femur fracture management. Cons of hardware is that you do get sort of this bony overgrowth, and so the risk of creating new fractures or making your future life as a total joint surgeon, if this person needs to have their hardware removed to get a total hip replacement, it just really complicates your life later. So quite often we're removing these. This is where I would have transitioned to the rest of the lower extremity fractures. I can get you guys these slides so that you've got them, but we're at time. So any questions at all before I let you go?
Just one quick question. So I haven't seen a spica put on yet, but for the groin area, do you just try to reinforce with waterproof tape, or what? Do you have any other tricks to help try to keep that clean and dry there?
Absolutely. So this is a single leg spica. You always have to create some space at the groin. And we at Oakland, and I imagine in San Fran as well, have the Gore-Tex pantaloon. So essentially this top white layer of the cast, you can see there's a little overlapped. It's just a Gore-Tex liner. The goal is that you can get that all the way up and over, and that's the basic approach to have your waterproof. But then, the pink kind of anesthesia tape, we also use that to reinforce around the edges if you have to, if you have a little break in that area. But yes, you need to try to maintain waterproof as best possible around that for diaper leaks, inevitable, soilage. So the Gore-Tex liner is usually the go-to for that.
Okay, thank you.
So I have another question. Also, for the indications for Xfix, in these, it seems like the one you said you started with an Xfix and then went to the plate. Is it like the same as in adults, like damage control, vascular, like those types of indications, or are you typically using it like prophylactically and then going in later?
Right. So
prophylactically, I should say, more like initial stabilization.
Yeah, exactly. I mean, I think it's mostly damage control orthopedics. Most kids with an isolated femur fracture are capable of tolerating a flexible nail if they're in that category, or directly to intramedullary nail. For those that are, in extremis or otherwise unable to, using an Xfix. So like for this kid, you can see, there were multiple abrasions, scattered, lacerations, had a head injury and whatnot. So we just put on the Xfix, came back and, reevaluated it at a later date. So pretty much the same approach for the adult world, but I would say we can get away with doing more aggressive, immediate surgical management, because usually they're not the multiply injured, frail people to begin with. So we can go straight to the intramedullary devices generally.
Sorry, I don't know if you already mentioned this, but what's the typical like post-op course for flexible nails, like in terms of weight bearing and everything?
Yep. So generally it's non-weight bearing until you see callus. Generally it's about 4 to 6 weeks at least. I would say most people will err on 6 weeks. The other sort of unique feature of PEDS is that you have to expect, well, I can't say it's unique because it happens in other aspects too. Like you have to expect that people are going to push the boundary. So if you tell a child non-weight bearing, they're probably going to do a little bit of touchdown weight bearing. If you tell a child touchdown weight bearing, they're probably going to be full weight bearing. So you kind of have to accommodate that. And that's where we will sometimes be more aggressive in the, non-weight bearing, we'll put casts on some kids just because we expect them to push the boundaries. So ultimately, from the standpoint of flexible nail, it's typically non-weight bearing to accommodate the mobility of the fracture until the callus is supporting it, because the flexible nails can bend. And if they do, it is a bummer of a day to address.
Sounds good. Thank you.
Cool. All right. Well, sorry I didn't get to the rest of them, but this I think is a helpful, deep dive into basic femur fractures to give you all at least a launching pad.